If I can have the panel please come to the front and do brief introductions. We have Dr. Mario Azevedo, Chair and Professor of the Department of History and Philosophy, College of Arts at Jackson State University. We also have Dr. Mohammed Shivazi, Professor of School of Health Sciences at Jackson State University. I think if we can start this discussion with, if we can get a brief reflection of both of your opinions about this document.
That mic works on the table.
Thank you very much, Dr. Williams. I'm pleased to be a member of this panel, and I'm extremely pleased that there are so many history majors here and professors in history that came to support us. Thank you. Thank you for your presence. I'm going to make very few, can you hear me?
Yeah.
Okay. Very few comments because we don't have much time, and I know there will be so many questions. Just want to make four very brief comments about the film, about the interview. First of all, I don't think it does define what health is. We talk about health throughout the interview, and nobody defined really what health is, as defined by the United Nations. It's a state of mental well-being and physical well-being, and not just the absence of disease or infirmity. Because you can be physically well, but something is not right here, and you are not in good health. The other item that I think they should be more clear about is the distinction between difference and disparities in health. You will always have differences, even if there is no racism whatsoever. There will be always differences between populations in terms of their health status. Disparities, there are differences, yes, but to it, there is the connotation of social injustice, that something should not be the way it is, that one race, one ethnic group, or one section of the population has better health than others, that social injustice can be corrected. And I think that's what disparities is or are for me. And the disparities come from several factors, we call them social determinants of health. But inequalities, they bring poverty, a major portion, a major element of disparity. That's number one. Number two, one of the panelists mentioned the Flexner report. That report came out in 1910, and it was commissioned by the American Medical Association, and it dealt with the issue of black universities, black schools, black medical schools. There were at that time in 1910 some 11 throughout the country. The Flexner report said only 3 were acceptable, that they did not have the resources, and that therefore they should not be allowed to exist. Eventually, only 2 were allowed to exist. There was Howard University Medical College and Meharry College. And that had an impact on the number of physicians that came from the black community. Really, it was really detrimental to the health of the black population in Mississippi. We can talk more about the Flexner report, but it also reflected the view of the American Medical Association at that time, which did not allow black people, black physicians to be a member of. The association was established in 1840, and until the 1960s, did not allow black physicians to be a part of it. And the issues of racism within the association were all known. For example, it was believed in the association that blacks had 9 inches less in their brains than the white medical establishment. And also there were very hard on blacks trying to publish in the journal of, what is JMA, to the extent that it wanted to prevent white people from reading black physicians' articles. They would put the name, beside the name of the black physicians, the letter C or COL. This article has been published by a colored person. And therefore, many physicians, white physicians, would not read that article. Eventually, the black physicians had to create their own association, their own journal to be able to publish. There was talk of optimism for the future, that the more minorities we're going to have, we're going to be better in health. I don't think that's the case, because the cake is going to be smaller, and if you don't have the right leadership, we're going to be even in a worse situation. And despite the fact that we were commended by the federal government in terms of immunizations and vaccinations of children, but that includes many other things, because health affects all elements of life. It's not just vaccinating children. What else do you do? Where is racism there? As long as we have racism in terms of education, in terms of employment, income, infrastructure, where the hospitals are located, I think things are going to get worse the more that we increase the number of people in the state of Mississippi. We're not at 3 million, but if we go to 4 million, I think the health state of the government will be worse. Last, I don't think that I'm optimistic about the future. Dr. Shabazz and I have an article in the book that I'm editing on health in Mississippi. And we went through all of the indices. And Mississippi is the last. We gave them a grade. We gave the state a grade, and it's a D or F or perhaps a C. I think I'm going to stop there so that Dr. Shabazz will have a chance to say something else.
Thank you. It's great to be here, and thank you for joining us. I want just to start with the statement that my former supervisor and colleague, Dr. Azevedo, about the optimism. I will also start at the national level, really. In this country, we are spending approximately $8,000 per person. And if you use the economic models, that you invest something and you want something in return. If we compare that 8,000 that we are spending in this nation with other developed countries, lesser countries, we are not getting the return. The life expectancy is what's one of the indicators is low. Still we have infant mortality rate in Mississippi, in Delta, it is twice, 50% more than, it's national level is about 6, 7, but Delta is 15. And then the same thing, we have been spending more and more money, even in Mississippi, and they mentioned that we are at the bottom, and we are at the bottom. And we basically have got, this is the way we are spending. Cost is going higher, and the outcome is not that much if it's at national level. At Mississippi level, we have, it's just amazing that we have high rate of obesity, as they said, high rates of diabetes, high rates of infant mortality rate, high rate of stroke, chronic disease, poor nutrition, reduced life expectancy. So we are at the bottom, everything is high. The question is, what's going on? Why is it, despite so much money we are spending at national level and in Mississippi, we don't see the result? The part of it is really the structure that we have. I believe that unless we address within that structure, because we have racism as an outsider for the past 15 years I've been here, there are people who tell me, how do you teach kids in Jackson State? That, to me, as an anthropologist, is a statement that the racism is in people, we have internalized. And as we overcome that, there's no way you can address health. And then when we are talking about, the other thing is, I think that as when we were talking about, we really need to have an integrated primary health care. So if I start from Delta and have had a level of sugar in my body or have blood pressure, to use lay person's term, I don't go to physician because I don't have one. Even the affordable care has not kicked in yet. So you get very sick, you go to hospital, and they are connecting you to all kinds of machines because now organs are failing. But this could be prevented by an integrated primary health care. You don't have to have a physician. You could have a community health worker, somebody trained to basically take them now they're using those machines to figure out your sugar level, send it to a doctor, and then follow up. Are people taking their medications? What are they doing? So we really need to have an integrated primary health care, integrated primary health care. And also, we really talk about communities. And we get money on behalf of communities, but you go to conferences, you go to places, communities are missing. They are absent. We're talking about social determinant of health, which is the environment where people are born with drugs. We are not really working with community. We are just coming, we are the expert, and we are going to do things. And I think I'm pessimist. I wish I could be an optimist. As a nation, we are not healthy. And as a Mississippi State, we are at the last, and something needs to be done.
I have a question for both of you based on the comments that you provided. Feel free to raise your hand if you have a question, but let me ask you, Dr. Acevedo. As I listened to Dr. Beach talk about how we define health disparity, I know for myself and for many other people, we have a set definition of it. I think she explained, and you attempted to explain as well, it's more of a comparison between one group and another group. Can you talk a little bit more about what are the best ways for us to identify in terms of where we are, instead of saying health disparity of our understanding of it, but what are some better indicators of it?
I think one that we're failing in Mississippi, despite the increase in immunizations and vaccinations of children, is controlling maternal and infant mortality. That's the greatest measure of any society in terms of its status of health for its people. And so if you, in Mississippi, down here, unfortunately, the United States rate has gone down. The United States used to be 22nd among 180 countries in terms of controlling or reducing infant mortality and maternal health. Now the U.S. is 80 among 160. In other words, we are losing the battle even against the other Western industrialized countries and some developing countries at this time. So you take those two measures, and of course, vaccination and immunization are important, but you, as I mentioned, you can have as many vaccine children, and there is no nutrition. If they go to school hungry, they don't have a place to play, and they grow stuck. Then really the system is terrible. It's not working.
Got a question here, and then we'll come right.
Okay, I got it in the middle. I didn't catch the whole thing, but on radio this morning they were talking about differentials in HIV infection rates, and that is an issue. How do you see that fitting into this history of health disparities in Mississippi?
Well, we're still at the bottom, despite the fact that there has been some improvement in Mississippi. But I was reading this morning, we are still the lowest in terms of controlling the infections of HIV and AIDS. And I think we're losing the battle even against developing countries. The developing countries, okay, we laugh at them and we say this health system is terrible, but they're putting a lot of emphasis on maternal health and infant mortality and various international organizations that are spending billions of dollars, like the Global Alliance for Vaccination and Immunization, like the President's PEPFAR, Bill and Melinda Gates. They're spending billions of dollars, and those dollars are being used, I think, because they are well controlled in the right way, so that the reduction in infant mortality and even in HIV Since 1985 to the present, in Africa, the reduction of HIV/AIDS infections has gone down by 25%. And I don't think that's what's happening here, especially in the black community.
Before I go to your question, and I'm a former employee at the Bureau of STD and HIV, so I kind of, from going back to 1997, I kind of know the history of HIV in Mississippi. From that point moving forward and some before then, a lot of this goes back to education. Yeah, the numbers nationally have gone down, but when you look on a statewide level, it still continues to be a problem. One of the things that's happened in the last 15 to 20 years in HIV is the funding, because there was a consortium back of healthcare, African-American healthcare professionals back in the late 90s that had to band together to get federal funding to come to minority populations to address those numbers. So one thing that shifted with funding, it's going from funding for education, and now most of the funding is for treatment and care. So, you know, that shift of educating is still there, but the money is not there as it was in years past. So a lot of this, in addition to, I mean, to answer your question, it goes back to the educational level, not educational level, but education across the board about HIV infection. Yes, ma'am, you have a question?
I just wanted to add what I mentioned. I think with little funding, other countries, you know, they are able to address some of the things that we have money, but don't address. Again, it goes back to the lack of structure. HIV rate is going high because once you identify somebody has and you really don't put that person into a structured way so that that person is followed up, you lose them. That's one thing. And then about the infant mortality rate or child, we have 68% teen pregnant in Mississippi Delta area, and nationally it was 41. I was visiting a hospital in Kansas where they receive all these babies from Delta. I asked how much it costs to keep a 6 months old baby alive. Over $1 million. Why? Because the baby is born to a teen mom. You know, you can blame the victim and say, mom, 13 years old, 14 years old, has no business to get, pregnant. But that's the reality. How do you deal providing some care to that teen mom so that she knows that she has to go to a doctor, that premature baby, and we know research has established that if baby is born with low birth rate, you're going to get all kinds of diseases. So really we do again going back, we have a structural problem that needs to be addressed. I don't think I don't want to disagree with you. The funding, money plays a role, but there are countries with 1/1000 of what we are spending on health. They are successful and they change the outcome because they are the system.
Yes, ma'am.
My question was basically about the health issue. Okay, people talk about, the country talk about health and people really need to be healthy. I know when I was going to school, it was mandatory for us, for everybody to go to the gym. But there is no more gym in school. Like my son's school doesn't have they don't go to gym and they don't have a mandatory, PE time. So, you could talk health all day long at, at the college levels and stuff like that, but should we, should it start at the schools? Shouldn't it be, something that they say, well, let's get PE back in schools? These kids don't have no clue what true exercise is. They have no clue. They don't know that, when you were in school that you had to run and you had to, this was something you had to do. The only thing they know how to do is pick up a vacuum controller, call a phone. So we can't be healthier if there's no, healthier ways to put it out.
Let me go to the panel.
And you're correct. I mean, we should have those classes, but you know how difficult it is. Even when you have PE and then you go home and you see 5 hours watching TV or on the computer, you're fighting. We can fight as much. Eventually it takes a sense of responsibility, will that I'm going to do this. Otherwise, we're not getting anywhere. We talking public health. Yeah, we need to do this. We ourselves are not doing any exercise. You know, I'm sitting in the office all day. Go on, continue sitting. You know, that's not the way. I know this is not the way it's supposed to be done. But you're correct.
So you have your hand up.
Yeah, Dr. Azevedo, I want to really commend you for not being afraid to say that race matters. We do hear panelists and people, you know, I had a few problems with film, but great film. I'm from the Delta, Mississippi, where when I lost my mother 4 years ago, and my mother was an educated teacher, but she had to travel from Lexington to Jackson, Mississippi. Our lesson there is the emergency with a helicopter. We don't have clinics in the Delta. I do agree with you too that Barron Banks got to also let my grandchildren know that I got to take them out to run. We know the farms are low, so since we know the farms are low, then we got to get up off our hours and we got to run with them. Because we know there's disparities. And I want to applaud you for letting us know that it might be getting worse, because even though when I was in Tooele, Mississippi, we didn't have all of those messy foods that we have now. So I might be a little bit more healthy then now than I was at that point. I mean, more healthy then than I am now. I ate potato chips and hot greens now.
And if I can just a quick comment about the obesity and the pediatric obesity issue in the state of Mississippi, a lot of it does fall back to home. I grew up in the Louisiana Delta, so I know what, I had a totally different diet back then than what I have right now. So a lot of it starts at the home, and some part of it, we communion around food. And so it's being passed on generation to generation. That's where you kind of address the link. But yeah, there are things that have been done in the school system and so forth to take that away. But again, I think that really starts at home. Right here in the black shirt and the young lady in the back, and then we'll come to you.
I have a couple of comments, and the way I see it is the structure. I call it the system to me. So particularly for Mississippi, but also for the U.S. But in Mississippi, it's a two-tiered, to me, system. So the system is perpetuated to function that way. So it creates the outcomes that it wants, or it continues to create the same outcomes. And it's worse now because the things that are being done, like she said in the movie, to create the outcomes that are bad because of the outcomes that are desired in the system. And so the people who have the better health are not, they don't feel any way, they have no empathy, input, encouragement, motivation, incentive, or anything because they feel they're outside of that. And so as long as they can continue to keep their system functioning, they don't see their numbers as falling in the 50th part of Mississippi. That's another group of people that isn't included in. And that system perpetuates because the systems function that way. And that's how they function in Mississippi. I'm in the medical profession, so I don't know if there's any other doctors here. So I can tell you, and I'm not from Mississippi, I'm a transplant, but I've been here 20+ years. And I can tell you the things that I've heard and seen, even recently, in the state of Mississippi shocked me. So I'm going to just tell you that, and I'm from the armed forces system. So I always compare things a little bit to the armed forces system, and that's the way I see Medgar Evers and other people. Because you go outside of the systems and you see something different. In the armed forces system, the education system, when I was young, so and I have gray hair, was already integrated. So granted, there's a lot of things lacking there still. We didn't have like professors, teachers who were happy, but the system's integrated. Same thing with the healthcare system. It has to work that way, or else our defense system would not function. So when it needs to function, it does. Okay, when it wants to function, it does. Again, it's still a system that is created still to fit within the two-tiered system, but it's obviously different. It's built a little different than the way Mississippi functions. The other thing is that the things that I've heard, I have been to a medical conference this year or last year, local, with the local doctors here in Mississippi, which is the other state medical association. And so we were talking about kidney transplants and diabetes and hypertension and what have you. So I asked the question to the speaker, because the majority of patients who require kidney transplants are 40, 45-year-old range, usually black males. That's true in the country, but also in the state. And so I said, well, that to me means that we're still not doing well treating or preventing. I mean, a lot of these things are preventable diseases, not even early detection, treat. I'm talking about preventable.
Yeah.
You know, so we're not doing very well with that. Or how well are we doing? You know, I'm in the weeds, so how well are we doing, you know, as a state? So the answer I got from a university physician was it's just bad luck. This is a medical reason, diagnosis, cause for that, whatever name you want to give, a difference, disparity, bad luck. Just bad luck that this group of people require this. So how are you going to address a problem if that's your problem? You know, in the 21st century. You know, and this is in a whole room of doctors. Okay, so and nobody said anything. It was quiet. So nobody, I was shocked. The second thing was in the same meeting. Dr. Nasheza was there. But we're talking about articles presented in medical journals. So there's an article that's in doctors, a couple articles tried to put in the state medical journal. It had to do with just what was being shown. But really about the local medical association not allowing black physicians into the group at the time. They had to go outside the state to go to medical school, number one. Number two, when they came back, they weren't allowed into the medical societies, and on and on and on. And the organization did not print the articles when they were sent. They had to go through this whole elaborate, I don't know what to call it, of seeing if the articles were okay to print. They had to go to legal, risk management, make sure it was all right to print. You know, because the doctors, Dr. Smith and them were still living. So they were worried about being sued. I'm not sure what their concerns were. But still, in the 21st century, within the last year, and these articles weren't even written by black physicians. Just they were written about them. You know, with their own words and input in it. So that just tells you where we are. We've got the Affordable Care Act, you know, and so we have the local hospitals that aren't on the plans, except one. You know, it's just, it's the way they function. And they function that way to keep the system working the way they need it to work. You know, so it's just, you know, they're not wanting to expand Medicaid for working people. And the same problem they have with bringing Medicaid to the city and past people. So, you know, I think I have to have optimism, okay? Because otherwise you would say it's hopeless. We can't be hopeless for our future generation. That's not what happened. My legacy is not going to be to leave hopelessness. But, you know, we have to, how do we address the structure of the system? You know, that's the whole problem with the Affordable Care Act. That's where the issue lies, okay? It's because it's changing the system. And that is not, you know, change is not very well received by people. And so, you know, those changes are not what the insurance companies want. They're not, you know, Blue Cross of Mississippi, which has contracts with the state, county, city. It's not on the Affordable Care Act plan. So, you know, it's all those things that tie all into that. And then, of course, the education system is within that system. And so, if you look at the private schools, or the reason people have private schools, is because they have PE. They have the President's Medal Award for whatever, every year for their kids. You know, so they have all the things that we had when we were younger. They didn't change, they don't have home mechanism, but they've got life skills and family counseling and whatever you want to call it. So now why would you run to that system if you think it's not needed in this system? I mean, you know, so there's just so much, you know, that track, you know, you have to be in a certain track to become a doctor now. You've got to be taking IB or biology or advanced placement. If you're not even in that track or you're not going to become a doctor. You know, it's just so many things that go on to continue the system, you know, the way it is.
I'm very
That's all I have.
yeah. Let me give a couple more comments here because I see some people getting ready to yes, ma'am, behind.
Yeah, I just wanted to say that I agree with Azevedo, Dr. Azevedo, on how can you see anything better when poor people don't have access to proper nutrition in the first place. Like she says, they give different lunches at private schools. You have dropping something out of a can and saying that's an adequate meal for a group of people just because it's cheaper doesn't mean that your body is getting the nutrition that it needs. That's why there's dental problems are so what they are, and nationally and especially, you know, in the state of Mississippi. For one, most people in Mississippi don't even have mental health care. For two, you don't get the nutrition needed from the food that you buy in the store. Why do you think Whole Foods advertises, we'll feed a family for $125 a week? Just please come get some fresh vegetables. Nobody gardens anymore. You see yards, they're barren. You know, and that's that you can. The way globalized food and with the way food is sent across countries and everything done, it's hard for the body to maintain its nutritional balance when you think that you're eating what, you know, you think you're eating good food, but you're not. And even when you go to the grocery store, you're not going to McDonald's, but you're just buying something out of a can.
And it's even multiplied when you look at food deserts and in the Delta where they can't have access to it.
Yeah, there is none.
You had
My point on it is that education, healthcare is directly related to education because if the parents aren't educated, it starts at home naturally. So if your parent isn't educated enough to know what healthy is or to know what healthy does as far as running or something as simple as brushing, flossing your teeth so that you won't catch bacteria within your mouth, then how can you promote that the next generation to be healthier if the parents don't know? Because there are natural ways to be healthy even without money, because I didn't come from a rich family, but we were healthy because of how we ate, how we acted as a family. My grandmother would get up and take her grandkids running just because she wanted to be healthy. So she was educated on how to be healthy, which made her kids healthy, and which in turn made us healthy. So as far as being healthy, yes, the money plays a big part when it comes to health care, as far as to be cared for in the hospital system and such as that. But to be naturally healthy, that comes directly from home. And of course, in school, you should have some kind of educational health class or something like that. Because I know when I was a PE, they never taught us a way to be healthy. It was just go in there and run around, throw some balls out, and do whatever you want.
Can I just
yes.
never got into, from the individual level to the society we live. I know parents who are very health conscious right here in Georgetown, Jackson, okay? And I know moms want to go out there and exercise, but there's no problem. And they know they need to buy healthy food. But there's no car, and there's no mom and dad store nearby. There's Walmart, which, it takes a car to get there. So part of that system and structure, yes, at the individual level, education is great, but I may have the information, but it's not a safe environment to go and walk. So we need to see the big picture, and then try to address those various components within it.
I would like to add to that we cannot wait forever. We can't wait forever. Why is it that in this age, you still have parents who don't know anything about health? Okay, who is responsible for that? You really have to go back to history, slavery, Jim Crow, the period of civil rights when you had so much opposition. And then now we're going back to segregated schools. You notice that? And see, Mississippi was one of those states that resisted desegregation really in a high degree. Just read the history of the Veterans Administration building there in the 1950s. The government here was ready to relinquish some $15 million from the federal government. And they had already bought the land. They were about to simply abandon that issue of building that because it was going to be desegregated to the extent that it went to a vote. And those who were for the building of the building won by one vote. UMC, University of Mississippi Medical Center, resisted segregation even when they got federal government said, we're going to give $5 million for your research and renew your building. They were resisted. Eventually they had to do it because they saw that St. Dominic's Hospital was getting some money and they were getting more beds. And I mean, you can go on and on and on. The first time that the UMC Medical Center was, had the first black resident was in 1965. Dr. Aaron Shirley showed it. Yeah? So it's the state. I mean, it's the system that she was talking about. They still be perpetuated because we have almost the same kind of leaders that are not taking care of.
We got about 15 minutes, actually, about
Yeah,
one
I want to
comment
say
right
that-
there, come from the side.
I want to say that there is reason to be hopeful. This Affordable Act, just because coming from Obama, says also good for you people to start, breathing. I think there's a hope. For the first time, there was a long time I had actually an opinion on my own people, saying we're spending $1 billion on prevention. But the Obama first actually, Obamacare, what you call it, is shifting the resources from treatment-based to prevention, and that's hope. And I think we need to all be supporting it, and we need to be conscious of it, that there is a hope, and we need to participate.
What I'm listening, it seems very interesting in terms that the Western form of medicine are working, whether the reasons are funding and disparity distribution of healthcare. I'm wondering if perhaps the approach should be moved in a direction in terms of introducing traditional medical practices. So, for example, during the days of slavery, African slaves used different types of plants to deal with various diseases and problems and so forth. So wondering if we can go back to the system, it would help, to get rid of some of the problems that we face today. What do you think?
I would say,
That's a major issue, and I'm glad you brought it up because I'm dealing with it in my own book. It's coming up maybe in 2 years. The colonial system in Kempla tried to eradicate all kinds of traditional medical practices. They wanted to introduce biomedical practices. And they found out that they couldn't do that. They could not eliminate that system that had been saving African lives for what, 2,000, 3,000 years. So they had to resort to training these African physicians to say that by traditional medicine is worse, it's killing people, it's not having any results. But those same doctors that were coming out of the biomedical schools, they themselves, even if they were Christians, they were going back to traditional medicine. So there are things that we can learn from traditional practices. We can't say that all of them are bad. Some are very bad. You have charlatans out there. But we should have maybe complementary medicine to make sure that those who cannot have biomedical treatment can go to traditional medicine rather than try to eliminate it.
Let me get a couple. Go ahead.
In medical transport, they are looking at biomedicine and ethnomedicine. And there's a lot of medicine and ethnomedicine that they work. But the problem is, if you bring that ethnomedicine to this country where the ultimate goal is to make money, my fear is that even ethnomedicine in the long term may turn into, impurity and just making money. And then there are certain amount of trees, or people use tree leaves, things, airborne medicines. But if you want to make money, you may take that pure things and add impure stuff in it just to make money. I think we have to be careful. It is great, but it has to be in the right hands.
Quick question. I know you mentioned something about, like, just we're not going to the hospital, something to that effect, just we're not going to the doctor. Could it just be a distrust of public or private health care provided? Could it really just be a distrust? Because I know I hear about my grandparents, people always say, if you're sick, just don't go to the doctor because you'll die. And so we often hear about people like, was this Todd Saget or something like that, wrote something about black experimentation. So could it be a distrust?
it's distrust, and it comes back from slavery again, from racial attitudes. You know, that you don't know this doctor, is he going to give me the right medication? Is he going to be nice to me? It's the lack of understanding of cultural attitudes. You know, cultural competence is missing in a lot of physicians. I'm sorry, doctor. They treat everybody the same way. No, it can't be done that. The Latinos, African Americans, Africans, they have had this oppression, sense of oppression for so long that it will take time for them to really believe that these doctors that have been trained in these official schools have their interest at heart and have our interest at their heart. It's difficult.
Oh, I forgot.
I had my hand up. I almost forgot what I wanted to say. First of all, I would like to commend everyone that put on this program. It's a great program. Also, I would like to ask the panelists, have they did any research in regards to cancer? Like awareness of cancer, especially within African American communities. Like, have you done any research in regards to cancer, breast cancer?
If I could say, the third panelist, who I guess was unable to make it, I know about another name, Asia. I know the agency, My Brother's Keeper, they've gotten funding to address a lot of different health issues, and cancer may be one of them, I'm not sure.
Okay.
We're public health experts, not
Okay.
really medical doctors. I have not published anything on research, but I know the types of cancers that affect black people more than white, like breast cancer, as you mentioned. So I read about it, but I can't say that I'm an expert in cancers.
Yeah, go ahead.
Go ahead here.
Just very briefly, I don't know if you've noticed, but whenever they talk about Ebola in Africa,
Yes.
they always refer to the people going to traditional healers as people going to witch doctors. I read the New York Times, and I don't know how many times I've heard that in the last few weeks.
But what do you do if you're suffering something that's going to kill you and there's nobody to help you? At least you go to somebody. That shows that people are trying to live. Doesn't mean that witch doctors have the kind of skills to help them, but it just shows that people are desperate.
It also shows to me, that they're, instead of saying traditional healer, the New York Times is saying witch doctors.
Right. That's
It's really disturbing.
Yeah. Here, and then the last comment would be, this gentleman right here.
I just wanted to, because a lot of things sound negative, the reasons I'm hopeful or this optimism is because if you look back in the past, we're doing fairly well. I mean, I think we're doing well from where we've come from. Particularly the dominant society had a less lengthy life trajectory in the past, where they were, and it takes time, again, the evolution of time to move forward. The problem is that with the current system, it continues to try to push people back, or to move people back, and that's where the problem is. But I'm optimistic because, we can
Where you
overcome
gotta be.
I wanted to see the panel's view on like mental health as far as healthy wise too, because I work in the field with mental health and psychiatric behavior facilities, and I see a lot of doctors actually doing a lot of misdiagnosing, especially when it comes to mood disorder or any type of just generalized behavior that we do on a daily basis. Like, in my opinion, I believe that if you're not diagnosing them with a certain type of mood disorder or a certain type of whatever, then, people have mood disorders daily because your mood's going to change. We're human, we're not robots. So at the end of the day, I feel like I see the medical field and doctors is just trying to just throw a pill to help every little issue, and everything revolves, like you said, at home. But at the same time, if you have no outlet or no education for the parents to go to and
half of them, to be honest and frank, they're just putting their child in there so they can get the check, basically. Then, in my regard, I feel like the pharmaceutical and the insurance and the doctors all run together. And that's where it comes with the trust issue, because I had an issue with myself where I had something going on with my stomach, and I was going to doctors, and it was like, okay, they're running one test, and then I come back, they're running different. Why you can't run all of them together and save you the money, so I won't be able to do that, then come to find out you're not even diagnosing it because you can't find a problem. That's what you let me know, but as soon as I stop taking those pills and start just eating vegetables and eating more healthy, then the problem goes away.
Let me I'm a licensed clinical psychologist, and so the mental health thing resonates with me. We don't have a lot of time, but I want to give a quick experience I had at the Mississippi Psychological Association conference about 3 weeks ago, where the panel I sat on, we talked about cultural issues facing African American psychologists. Well, my issue is that since I'm a former graduate of the clinical program that I'm over at Jackson State, I've met only one black psychologist, male psychologist, since I was a student. So when you look at the same type of issues we're talking about, medical related, health related issues, in the mental health field, that's a whole other different discussion about when you get to stereotypes, beliefs, and all those different things and misnomers about mental health, and African Americans' perspective about mental health. It opens a whole different drawer of these types of discussions. But there was a gentleman from Washington, D.C. He was the executive director of this National Credentialing Board for Psychologists. He was shocked that I'd only met one black male psychologist since I've been in the state of Mississippi, since I was a student in the program, to the point that he's having a meeting to hopefully kind of generate some funds for our program to recruit more male psychologists. So when you brought up the mental health field, that's a whole other different component that has a lot to do with the central focus of this discussion that we can go on and on about. But we want to kind of stay on time. We got a couple minutes left. I want to at least give the panel an opportunity to kind of give a closing opinion.
As I said at the beginning that I was not optimistic. I still maintain that, because most of what we're trying to do is never materialize. But regarding your question, it's unfortunate now that a lot of states are giving more attention to mental health. It's only during the last 10 years that really that subject has been very important. And you may want to know that last year or 2 years ago, the federal government came to Mississippi and to praise Mississippi for doing better than most states in terms of health, mental health, and they wanted to know what were the tricks that the state of Mississippi was using that the other states did not know and were not using. So there's some optimism in terms of mental health, but how long is it going to last?
I would definitely say that mistrust is a main issue in health. And the other thing is, you actually started saying, we're not that optimistic. At the same time, I think we, in academia, people practicing, I think we are really working in isolation. We need to work together. Often we, get money repeating. How many times do we need to get the research money, our tax money, and prove and show that walking is good for you? We know that. Why don't we create environments where people can walk? So, working together, I think there's going to be hope. And again, the Affordable Act is really shifting the resources to prevention, and I think we need to do more prevention. There's no reason somebody who could be diagnosed with the high level of sugar in his or her blood to be waiting till he or she is connected to the machine, and everybody's making money. The fact is that in this country, money-driven country, we are counting people, figures, not money. I was talking to a doctor who has a contract. He has to have a certain number of patients in order to renew his contract. We need to stop that. I mean, that means you have to discharge somebody, readmit, and all that, so you can have your job. So I think with the Affordable Act and with the shift Health People 2020, the mandate that we want to have more prevention. There is a hope, but at the same time, we need to work together.
Thank you, Dr. Shavazi. Thank you, Dr. Acevedo. Thank you, Kofo, Dr. Chapman.